Hello everyone, this is the fourth and the last part for Chancroid, and today we'll study the diagnosis and treatment of the disease. Starting with the diagnosis of Chancroid, the first thing is the microscopy of the specimen. Here will be the ulcer exudate, or you can even take the aspirate from the bubo. What we do is we either gram stain it or we can also GMSA stain it. What we see in gram staining or the GMSA staining is that there are gram negative coccobacilli. Each bacilli is arranged end to end, and these are in parallel lines, as we can see in the picture. This arrangement is also known as school of fish, railroad track, or fingerprint arrangement because of the similarity. Next is culture. We can usually culture the bacteria from the ulcer exudate, though it can rarely be done from the buboaspirate as well. So, since there is no transport media for this bacteria, it is immediately inoculated into the specific media for Haemophilus ducreyi, and they are Muller-Hinton, Gonococci agar base, and heart infusion agar. Since these bacteria need factor 10, we add some form of blood or its component into each of the agar. To make the media more selective, sometimes vancomycin is also added to inhibit the growth of other bacteria. We see yellow non-mucoid translucent colonies, yellow-gray colonies, and these colonies can be nudged, that means moved from side to side over the agar surface. Just a picture to show the colonies. Now moving on. Next method is antigen detection test. These use monoclonal antibodies against the hemoglobin receptor on the outer membrane protein of Haemophilus ducreyi. These tests are not commercially available. Moving on to serology or the antibody detection tests. Here there are many methods that can be used. Some of them are ELISA, complement fixation, or agglutination tests. These are used for epidemiological purposes only. Next in the queue is the biopsy and histopathology, which is not really needed, but these are done to exclude or rule out malignancy. In histopathology, we basically see three zones. The uppermost zone is composed of necrotic material with a lot of neutrophils in it. This is not much in thickness. The next zone, or the middle zone, is the broadest or the thickest. So what are these? These are granulation tissue, and they have a lot of blood vessels within them. This is the reason the ulcer bleeds easily. The last zone, the lowermost zone, is composed of inflammatory infiltrate of lymphocytes plasma cells and histiocytes. So this is just a diagrammatic representation of the biopsy finding. I couldn't get a free picture to demonstrate it. Next in the queue is the Ito-Reed-Stirner test. In this test, this is an intradermal test. So in this test, what we do, we give an injection intradermally. Injection of what? It is a preparation of, or you can say vaccine of killed Haemophilus ducreyi bacteria. So we give this injection intradermally and then we wait for 48 hours. After 48 hours, if there is a papule over the injection site of like equal to or more than 0.5 centimeter or 5 mm, we consider this test positive. This is similar in lines of tuberculin test or the Mantoux test of tuberculosis, but this is now of historical importance only. Next is nucleic acid amplification test, which can be done by PCR, polymerase chain reaction, or multiplex PCR. In multiplex PCR, what we do, it allows for amplification of multiple DNA targets in a single PCR reaction using multiple primer sets. So where do we use this in Chancroid? Here we can use multiplex PCR is made for 3 diseases. One is Chancroid, the another one is syphilis and herpes genitalis or the HSV. So the 3 causative agents, that is Haemophilus ducreyi, Treponema pallidum and HSV, can be simultaneously worked up for or can be detected in a single PCR session. Now moving on to the treatment of Chancroid. First we'll go through the CDC guidelines for this disease. It is from the year 2021. So in diagnosis, they have given a paragraph in CDC guidelines. Here it is written that one or more deep and painful genital ulcers and tender suppurative inguinal and adenopathy, if present, is Chancroid. This is pathognomic. So they have given a criteria for both clinical and surveillance purposes, and the probable diagnosis of Chancroid is made if all the criteria are met. So the first criteria is one or more painful genital ulcers. The second is if the first criteria, that is the ulcer, are clinically in line with the morphology of Chancroid, there is a regional lymphadenopathy. This is the second criteria. The third and fourth criteria is exclusion of syphilis and herpes genitalis. So now we'll write down the 4 criteria. The first one is there are multiple painful genital ulcers and it is consistent with the morphology of the Chancroid ulcer. The second is regional lymphadenopathy. The third is you have to rule out syphilis, and the fourth is you have to rule out herpes genitalis. For ruling out or excluding syphilis, they have written either by dark field examination or nucleic acid amplification test of the ulcer exudate or serous fluid, or by serological tests which should be performed within 7 to 14 days of the onset of the ulcer. For herpes, we can either do NAAT or HSV culture. So here for all the 3 organisms, multiplex PCR comes very handy. Now we'll move on to the treatment, that is according to the CDC guidelines. Here they have given 4 drugs. The first and the most preferred drug is azithromycin. It is 1 gram orally and a single dose of azithromycin will suffice. Or you can give ceftriaxone 250 mg IM in a single dose. If we go for, if we remember back in gonorrhea, it was 500 mg of ceftriaxone. Here it is only 250 mg. The third one is ciprofloxacin 500 mg twice daily for 3 days. And the last one is erythromycin base 500 mg orally thrice daily for 7 days. We should always do a follow-up of the patient in STI. The follow-up should be done in Chancroid in 3 to 7 days. In 3 days the symptoms improve, and in 7 days there is improvement in the ulcers. Also there should be partner treatment of the patient. So all the partners within the last 10 days should be treated with the same regimen. This was about the treatment of ulcer, but if there is a bubo, it is recommended to continue the antibiotics until the bubo heals. It might also need IND and other surgical interventions. For the care of ulcers, there should be regular dressing and cleaning. So there are some special population. In pregnancy and in patient with a concomitant HIV infection, the regimen remains the same. In pregnancy, they have given a special mention for ciprofloxacin, though it is of low risk for the fetus during pregnancy, but there can be toxicity in breastfeeding, so it should be avoided in lactation. All the 4 drugs are safe in pregnancy, and azithromycin is preferred because of the single oral dose. In HIV infected patients, there are frequent treatment failures and they need repeated dosing for the treatment. There is an interesting point in the paragraph for children. Though all the genital or perineal ulcers should raise high suspicion for sexual abuse, but there are endemic areas of yours where if you find a cutaneous Chancroid ulcer, it is non-sexual. These are usually the tropical regions and the ulcer is usually in the lower extremities. Now we'll move on to the syndromic approach for genital ulcer disease according to the National AIDS Control Organization. So kit 3, which is white, and kit 4, which is blue, are for these genital ulcer disease, which is either syphilis or chancroid. They are non-herpetic ulcers. So what does these kit contain? Kit 3 contains injection benzathine penicillin 2.4 million units to be given stat, and tablet azithromycin 1 gram or 1000 milligram for a single dose. Both is for a single dose. There are 3 other things which can be asked. It is a disposable syringe of 10 ml, 21 gauge needle and sterile water of 10 ml. In kit 4, the blue kit, is oral doxycycline 100 mg 28 capsules, and it is given twice daily for 14 days, and azithromycin 1 gram for a single dose. This blue kit is given when there is either unavailability or history of allergy to benzathine penicillin. In WHO guidelines June 2021, it is written to treat chancroid only in geographical areas where there is re-emergence of such cases. And when there is such clinical suspicious cases of chancroid, the national authorities should be informed and then the case should be treated. So in the table for syndromic approach in WHO, they haven't included chancroid, they have only included syphilis and herpes. With this we have completed the whole topic of chancroid. This was the 4th and the last part. In the next class we will be studying the next genital ulcer disease. So thank you for now. Bye.